probably saved under a filter or something. That's what it's like at.
Okay, so the first thing we're looking at is each area. The SA node, this is where you see your P wave. AV node rates 40 to 60 beats a minute normally. That's the little dip that comes right before the QRS. I'll go over that in a second. The ventricular rate is 40. If it's firing from the ventricles, then it's going to be a rate of 40. This is the QRS. The T wave is the repolarization of the cells when they're recovering from the beat and getting ready for the next beat. Okay, the easiest way to remember the rhythm, what it could be, is there a P wave? If there's a P wave, then you automatically know it's coming from the SA node. It could be AFib, it could be A flutter, could be all kinds of other stuff we'll get into in a second. But you know if there's a P wave that it is coming from the SA node. Next is your AV node, which is your PQ interval right here. That one really isn't important at all, too much to look into. But then this is your QRS. It's less than 0.12 seconds. PR interval should be less than 0.20. And T wave is here. That's your repolarization. That's where you'll get to see in your ST elevation and STEMIs and stuff, and that would be up here. But I'll show that in a second too. But that's just the basics of what the strip should look like under all normal conditions. Okay, so we just went over the normal sinus rhythm. Next rhythm you're going to be looking at is some that you'll see quite often, but there's no treatment for. That's a first degree heart block. It looks just the same as the regular. Only difference is this section right here, your PR interval is greater than 0.20. It's very common that you'll see this, but there's no treatment for it, and most people's walking around with no signs or symptoms from it. So when you see it, it's not much of a problem. The next atrial rhythm is the one that you'll see more than anything, and that's AFib. AFib is a bunch of P waves firing, and then a QRS. P waves, P waves, P waves, P waves, QRS. There's no rhyme or rhythm between it. This is irregular. So there's no rhyme or reason behind it. It's just a bunch of random firings. The P waves are firing at a rate of anywhere between 200 and 300 a minute, but the QRS is just getting one out ever so often because only so many beats can make it from that SA node through the AV node to make it to the ventricles to fire to cause the QRS to go off and actually have a beat. Next rhythm we'll look at real quick is one I've never actually seen in person, but you'll see it on tests and stuff, and I'm sure in cardiac you may see more. It's A flutter. It is a regular rhythm, and it has sawtooth P waves. You'll see them. They're very distinguished. It looks like a saw. And then you'll see your QRS. Usually these are regular as well, and a lot of times they'll come at a conduction rate of anywhere of, like this one right here would be 1, 2, 3, 4, 5. 5 to 1. So there's 5 P waves to every 1 QRS. And you would see that continue throughout the trend. You would see 1, 2, 3, 4, 5 P waves, sawtooth P waves, and then a QRS. That's A flutter. Treatment's pretty much the same for that one as well as AFib, depending on if they're symptomatic or not. Like any atrial rhythm, the treatment is usually just cardiazem. Okay, the next one is one that is a critical rhythm as well. I'm sure you're familiar with it too. It's SVT. SVT is a great rate greater than 150. If you have a sinus rhythm, normal sinus rhythm, with a rate that's anywhere from 100 to 150, then it's just sinus tach. And usually they can perfuse pretty well with that. Once you get to going over 150, 160 area, depending on where you're at and what the protocol says, will be considered SVT. SVT needs to be treated because you cannot perfuse. The heart doesn't have enough time to fill the pump with that kind of rate. SVT, the hallmark sign is you will very rarely see P waves. There's P waves, but most of the time they are buried inside of the QRS because they're firing so fast. That is treated depending on if they're symptomatic or unsymptomatic, sick versus not sick. If they're sick, low blood pressure, shortness of air, whatever be the case, then you're looking at synchronized cardioversion, which I don't know how familiar you are with a monitor. That is a very important thing, is to make sure if you do go to cardiovert that you do hit the sync button. If you don't hit the sync button, they will go into asystole. So make sure when you do that, it is synchronized. If it's a stable rhythm, the patient's stable, then treatment is just drugs such as adenosine, Cardiazem, whatever be the case that the protocol there would be. On this one too, you can see runs of it. If you see runs of it, you'll see a run of SVT, then it goes into just a normal sinus rhythm. That's what's called paroxysmal SVT. And if you see that, it's usually a good indicator that they will go into full-blown SVT at some point. That's a good point to catch it, start treatment before it does become a problem. Now, going back to the AV node, that's a rate of 40 to 60. When you see that, you'll see an EKG strip that has no P wave, but has a QRS that is narrow. It's a narrow QRS without a P wave. This can be common in a lot of people too. In a lot of athletes or people who are really healthy, you could see something that looks similar to this. A lot of times there's not much treatment for that unless they're symptomatic. If they become symptomatic, then you have to have a pacemaker, at which point they will come in and the pacemaker will become the new SA node for the patient. So this can be done. You'll very rarely see external transcutaneous pacing done for this. Usually it's a surgery with a internally implanted pacemaker to take over the SA node. This as well, we'll talk about these right now as we go into this part. We'll look at PVCs. PVC is a normal sinus rhythm right here. And then over here you'll see something huge. Big beat like that right there. Something crazy looking would be a PVC. But you can also see PJCs, which are these. It is just a random beat somewhere in between the normal sinus rhythm without that. No P wave there. So you can see PVCs, PACs, PJCs, whatever be the case. If there's a beat somewhere that it ain't supposed to be, and it's got a P wave, it's a PAC. If it don't have a P wave, then it's a PJC, premature junctional contraction. If it don't have none of that, it's weird and wonky looking like that there, PVC, premature ventricular contraction. And you can see these come in more than one. You'll see them referred to a lot of times as, if you see 1 and 2, those are called couplets. If they come in a rate of 3, they're triplets. And you can also see what's called ventricular bigeminy or trigeminy. That would be a normal sinus rhythm with PVC. Normal sinus rhythm, PVC. Every second beat would be a PVC. Same thing for trigeminy. It would be every third beat. You would see normal sinus, and then a PVC if it was ventricular trigeminy. Now, I mentioned those triplets before, which is 3. If you see any more than 3, that becomes VTAC. It can be a run of VTAC. It can be sustained VTAC. Regardless of the case, anytime there is a run of VTAC or sustained VTAC, go check your patient, notify the provider, whatever be the case right away. That's something that needs treated. The patient cannot perfuse in ventricular tachycardia. Always check for a pulse. I've had multiple patients that's been in ventricular tachycardia look at me and talk to me and be stable, but they're not going to be stable long if they are in VTAC. Treatment for this, amiodarone, lidocaine, whatever be the case. If symptomatic, once again, if they got a pulse, synchronized cardioversion, no pulse, defibrillation. Once again, synchronize is very important with that one as well, as they will go immediately into asystole if you do not synchronize cardiovert and just defibrillate.